So for those who may not know me, I'm Paul Orchard. I'm in the bone marrow transplant division. Welcome to the Crivet Lectureship. So I wanted to take a minute as we get started. So those of us that have been around here for a while know Bill, knew Bill. But some of the people, especially the residents and whatnot that relatively new, may not have known Bill and may not know what his contributions were. So I've been having this lectureship for about 15 years, I think now, 14 years maybe. And so Dr. Crivet was a fixture here at Minnesota for many years. So somebody pointed out to me this is 2051 to 05. That's not actually when he was born. That is actually the time that he served as faculty here in Minnesota. So he got started in hematology and oncology, made some great contributions in oncology. He helped develop what currently is the clinical oncology group. He had important studies in coagulation, leukemia, and whatnot too, but primarily known as a bone marrow transplanter. And his legacy, at least in my view of things, is the use of cell transplantation for diseases that are non-malignant, and particularly metabolic storage diseases. So back in the late 60s, people learned that if you mix cells that are enzyme together with cells that are producing enzyme, you can correct the cells that are enzyme deficient. So this cross-correction discovery led to the use of transplantation for many enzyme deficiencies. And Bill was really on the forefront of that, had a number of grants, really put Minnesota on the map as one of the pioneers in this area. And so every year we've been having a lectureship related to the diseases that Bill worked closely in. And so one of those is adrenoleukodystrophy. He was one of the first people to publish the use of transplantation in ALD. And we have the pleasure of having Marc Engelen here with us today, who's from Amsterdam, who's a neurologist and internationally known in ALD. One of the things, too, for the residents is adrenoleukodystrophy is now on the newborn screening panel. And so people, as you get out in the world and are going to be serving your patients, you may get some of these calls that there's a baby born that was identified as having ALD. So being aware of these types of diseases is going to be important for you down the road. So we do a lot of transplantation in cerebral disease, and Marc's going to talk, I think, primarily about some of the other phenotypes that we need to be aware of as well. So, with no more ado, I think. Dr. Engelen.
Thank you very much, Paul, and the entire BMT group for inviting me for this lecture. I'm deeply honored and having great fun so far. And I'm not only talking about the wonderful local beers, but there's one thing I'm a little bit worried about, since I'm going to be discussing some of our studies in adrenoleukodystrophy. But today I understand that the audience is composed mainly of pediatricians. And although adrenoleukodystrophy is a disease that affects children, a lot of the patients actually develop symptoms in adulthood, and I'm primarily going to be talking about that. But I hope that it still will be of interest to you. So before I go into the results of our natural history study, I would like to give a not so brief introduction on adrenoleukodystrophy, because it is not a very rare disease, and especially if you work in this center, this is one of the, I think, the leading centers for bone marrow transplant for these patients. You are very likely to encounter them from time to time. So adrenoleukodystrophy is a metabolic disease. It is a paroxysomal metabolic disease, and it is caused by mutations in the so-called ABCD1 gene, which is X-linked, and it codes for ALD protein, not very originally named, but ALD protein is involved in transporting very long-chain fatty CoAs into the peroxisome where they are degraded by beta oxidation. And deficiency of this ALDP leads to severely deficient beta oxidation and therefore accumulation of mainly C26 and other very long-chain fatty acids that cannot be degraded in mitochondria in virtually all tissues of the body. It is really not that rare. We estimate that there are more than 10,000 patients in Europe. And many of them, the ones that do not present in childhood, are often not diagnosed or diagnosed very late in life. Clinically, it's a rather complicated disorder with a very wide clinical spectrum. And it is important to note that even though it is an X-linked disorder, women are absolutely affected, only differently from men. So how is the diagnosis made? Well, easily, if you know what test to order. No, but because the very long-chain fatty acid accumulates in all tissues, there's a very easy diagnostic assay, and that is to determine total C26 in plasma. It's a very easy test, and in male patients you pick up 100% virtually of affected persons. For women, it's a little bit more complicated. As you can see in this graph, there's a proportion of women, about 15%, who have normal very long-chain fatty acids and are still affected. So these need to be diagnosed by DNA tests. Then, the clinical features. The term adrenoleukodystrophy is relatively recent, but as is often the case, if you have a certain disease and you look back in the old literature, actually, usually the disease has been described before. And that is the same thing with adrenoleukodystrophy. Already at the beginning of the 20th century, there are cases, clinical pathological studies, that probably describe adrenoleukodystrophy. And they are the most dramatic presentation of adrenoleukodystrophy, what we would now call cerebral ALD. And those are characterized by previously healthy boys who deteriorate rapidly, usually somewhere between, let's say, 4 and 10 years of age, develop behavioral disturbances, cognitive deficits, seizures, then prominent spasticity, and die in a vegetative state a few years after symptom onset. And of course, in that period, the disease, the cause was not known. It was considered very rare. And it was called, well, with these beautiful old German descriptions, Bronzenkrankheit and sklerosierende encephalomyelitis. But these were very fragmented. Oh, sorry. Well, later on, in the 1950s, this disorder was studied more systematically, and it was first noted on electron microscopy of autopsy materials that there seemed to be some kind of strange depositions in nervous tissue. And in 1976, it was discovered, actually by accident, because somebody forgot to turn off the gas chromatograph, that there was a very strange peak with a very high mass lipid, and that turned out to be the very long-chain fatty acids. And it was an important breakthrough, because now, for the first time, there was a biomarker with which to confirm the disease. And this led to a very rapid expansion of the clinical spectrum, because also in the 1940s and 50s, there were reports of people who developed what neurologists call hereditary spastic paraparesis. There's a progressive chronic myelopathy with adrenal failure. And adrenal failure, I forgot to mention, is also a prominent symptom of those boys with cerebral ALD. But this was not, the dots were not connected. This was considered a different disease. There are many HSP, so nobody put those cases together. But now that there was a biomarker in the late 1970s, actually here in the US and in Austria, there were two groups who discovered that these men with the progressive spastic paraparesis and adrenal failure actually had the same disease. And they could confirm that by doing the very long-chain fatty acid assay. So that was an enormous extension of the phenotype, because now there was a confirmatory biomarker. And actually, it turns out what became known as adrenomyeloneuropathy was actually a much more frequent manifestation of adrenoleukodystrophy. And it is very easy to recognize if you see many of those patients. Typically, this man is only 25, and you can see most patients with ALD have very prominent balding very early in life. I mean, if he was 55 or something, it would not be so remarkable, but for 25, this is unusual. And you can also see the hair is usually very thin and curly. And usually in the third decade, prominent spasticity occurs, gradually progressive, due to myelopathy, which affects the pyramidal tracts, but also the dorsal columns. And there's also a peripheral neuropathy, which is clinically not so relevant, but which you can clearly demonstrate on electrophysiological testing. And what is also interesting to note, these people live very long. You have a normal life expectancy, basically, with this manifestation of the disease. But even however old they get, arms are never affected, which is important for counseling. Well, then, most male patients would develop adrenal failure at some point, often also at very young age, and this is often the presenting symptom. So many pediatricians are very aware of this, and if they have a boy with adrenal failure, especially if there's no autoantibodies, then they will often test, and this is a very frequent presenting symptom. But in my experience, endocrinologists are very alert. And what is unusual is that we find that most patients with ALD are only glucocorticoid deficient, in contrast to autoimmune Addison, in which most patients are also mineralocorticoid deficient. Then there's the women with ALD. And women with ALD, they're definitely patients. They're not carriers, they're patients. And what do they develop? They develop an AMN-like disease. They do develop a myelopathy, but with differences. The onset of the myelopathy is usually at a later age. As we will see later on in the talk, most men become symptomatic in their early 20s, and most women become symptomatic over 40 or even over 50. But they do develop a myelopathy. And also an axonal neuropathy. Again, clinically not so relevant. The problems they have in daily life are related to the myelopathy. And what is strange is that we don't understand why, but women have very prominent fecal incontinence as a symptom of their myelopathy more than the men. Don't understand why. So if you put it all together, then this is the picture that emerges. This is a fictional kindred of an ALD family. And the one thing you notice that all the different disease manifestations occur in one family. So there is no genotype-phenotype correlation. The clinical course is completely unpredictable. You can have boys with only adrenal failure, but you can have severely affected cerebral ALD patients, etc. So that is puzzling. So there must be other factors that determine the specific disease manifestations. The only thing that is a problem with this representation of ALD is that if you look at it, it seems like it's very static, that you get the one manifestation or the other. And that is something that is probably not true. Because if you see a lot of these patients over time, you see that they do tend to develop, go from one little box into the other. You have males with a myelopathy who develop cerebral ALD. And in the older literature, that was always considered rare, cerebral ALD in adulthood, but that is probably not true. I mean, if you have enough of these patients, it's something that you encounter quite a bit. So maybe cerebral ALD is not very rare in adulthood. And also, well, the women, of course, they were a neglected group, but they are definitely patients. And also something that's kind of supports the idea that ALD is kind of a chronic progressive neurodegenerative disease and not all kinds of very specific phenotypes, is the fact that after a successful bone marrow transplant, which is very effective in early stages to halt the cerebral demyelination, we looked at 5 boys who were transplanted at a young age when they had no myelopathy. They were transplanted because they developed cerebral disease. You can see that in adulthood, in their mid-20s, we found that 3 had clear signs of myelopathy. So apparently the bone marrow transplant stops one aspect of the disease, the cerebral ALD, but it does not stop the occurrence of the chronic progressive myelopathy later in life. And of course, we are not sure whether the progression is slowed, whether it's an attenuated phenotype, but it does suggest that there are different mechanisms at work, and that bone marrow transplant is not the solution for all manifestations of the disease. So it's probably more correct to consider ALD like this. It's also important for the newborn screening discussion. All male patients and female patients are born asymptomatic, or maybe it's more correct to say pre-symptomatic. But anyway, clinically, there's no way to pick them up before symptoms occur. And what symptoms occur? Well, virtually most male patients will develop adrenal insufficiency and myelopathy at some point, where adrenal insufficiency is often the first symptom in early childhood, the myelopathy usually in the 3rd or 4th decade of life. And then there's a proportion of patients, we don't know exactly how many, that will develop cerebral ALD, mostly in childhood probably, but also in adulthood. And there must be other factors than the mutation in ABCD1. There must be all kinds of genetic and probably also genetic environmental factors that determine whether there's an extra hit and somebody will develop cerebral ALD on top of the other problems. And yeah, these numbers are probably, there's a lot of discussion going on about them, because if you, what is the earliest age at which you can develop symptoms? Well, we think, no, it's correct. I think around 3, but there's also reports of even younger babies that develop symptoms. That is something that is open for debate. So, what do you do then if you identify patients? Well, what you can do for them, we have no treatment at this time to halt the myelopathy. There's only supportive care for the myelopathy. But the bone marrow transplanters can cure cerebral ALD if they are picked up in an early stage, if there's no deficits and as little MRI abnormalities as possible. So what do? After the diagnosis is made, endocrinologist follows up the adrenal function and treats if necessary, and we scan them. And then we scan them if they're between 3 and 12. We scan them twice a year, because we think that this is the high-risk age for developing cerebral ALD, and for the patients over 12, we scan them yearly. And if abnormalities develop, if you see the gadolinium-enhancing lesions in a very early stage, you transfer them to a bone marrow transplant team to transplant. But this, since neonatal screening has been implemented in some states, actually in Minnesota, as I recently learned, you've got patients coming in much earlier than what we're used to. You get babies, basically. And yeah, there's much debate going on whether this is still adequate, whether you should maybe start screening earlier or not. But lots of new patients in some areas of the world coming into the follow-up. And there's some problems with that, because, well, as you saw, the clinical course of ALD is very unpredictable. So when a new patient presents, especially when he's picked up by newborn screening, or as happens often these days, by untargeted exome sequencing, you get a lot of surprises there too. And what we do now with male patients is we give them very intensive follow-up. We scan them all the time. which is quite a burden on patients and families and healthcare systems. And maybe there's a health hazard too. We give them a general anesthesia when they're under 6. We give them lots of gadolinium every time. So basically, the intensive follow-up is necessary at this time, because if you wait for cerebral ALD to manifest clinically, you are usually too late for a successful transplant. So there is definitely benefit from screening, but there's also a problem, because maybe 60 or 70% of boys you scan will never develop cerebral disease, and you scan them for nothing. So it would be great if we had something to predict who would get cerebral ALD and who wouldn't, but we can't. Furthermore, there's the clinical trial readiness issue. There's lots of companies now who are working on compounds to try to stabilize the myelopathy of AMN. But actually, even though we think we know natural history, we don't really have, solid quantitative data on how fast the progression is. Because for neurologists, it's very easy to determine if somebody has a myelopathy. It's not so easy to determine if the myelopathy is worse than last year. We don't really have good tools to quantify myelopathy. And that is a problem in clinical trials. Yeah, and further, of course, there is no curative treatment for ALD, only for the cerebral ALD. And of course, you can treat the adrenal failure. So, this is the point where I'll start boring you with endless tables and numbers. How much time do I have left? Well, enough to show a lot of tables. But I'll try to keep it manageable. Now, so this is what we always did, what everybody in the world does. The standard care is yearly or twice yearly clinical visit for physical examination, for a very simple 15-minute MRI scan, FLAIR, T1, GADO, some lab tests if the endocrinologist wants it. That's it. Takes 30-40 minutes, and then you get the clean bill of health for the next year or not. So what we did, we figured, well, they're going to be coming in anyway. So what we do now, we entertain every patient a full day in the hospital. So we do a 90-minute MRI scan with all kinds of fancy new techniques. We collect lots of material. We PAX gene tubes for RNA, plasma cells for the biobank. We collect CSF if they will let us. And we do very extensive clinometry with all kinds of, 6-minute walk test, get up and go. And we repeat that every visit. And the idea is, and spoiler alert, we didn't succeed yet, is to find biomarkers that can predict the onset of cerebral ALD. Because in an ideal situation, you would classify patients as high risk and low risk, and have the high risk patients come in frequently for follow-up and, leave the low risk patients alone. But that is something that is, that's something that I think we will need a lot more time for. Then we did the prospective data collection to define the natural history and to look to see if we can find new surrogate outcomes. As you will see later, if you want to do a clinical trial with AMN patients, you need a long observation time. With the primitive tools we have now, you need a trial of at least 2 years. And we're looking to see if optical coherence tomography or quantitative MRI might be able to detect progression faster than all your conventional clinical methods. And the eventual goal is that this will benefit the development of new treatments. So now the endless tables. At this point we saw 65 women once for a follow-up visit, and we saw 61 boys and men for 3 visits. And of course, this is an ongoing project. The more, the better. So first, the data from the women. We had 46 women that we examined more than 5 years ago. Tried to find new women in our area, and the objective of this study was to cross-sectionally assess the symptoms of women in a larger cohort to kind of verify the earlier findings. And the other objective was to assess the progression of myelopathy. How progressive is it in women? And to do that, the outcome measures were a little simpler than in men. We just looked at neurological examinations and history, symptoms and signs. And we defined myelopathy as the presence of characteristic symptoms like urinary frequency or a gait disorder with abnormalities on neurological examination. So absent vibration sense, pathological reflexes, etc. And we used the very old EDSS and SF-36 quality of life scales. So this is how it looks schematically. So we had the previously reported 46 baseline assessments, and we pooled that with our the new women. So this was our baseline data, and we had 34 follow-up assessments, and we unfortunately had 12 women who were lost to follow-up for various reasons. So that gave us 65 baseline assessments. And yeah, this is where most pediatricians are probably zoning out now. The average age was 50 years, with of course some spread, but it was definitely skewed to the older women. And thank goodness, sometimes it's good when you can reproduce earlier findings. In this larger cohort, there's hardly any change in the numbers. And you can see that young women under 40 are rarely affected, and with age there's a very strong increase in women with myelopathy, and older women over 60, most are affected. But this is basically, give or take 1 or 2%, the same as for the earlier cohort. Now maybe if briefly look at what kind of symptoms they experience. Of course, the typical symptoms you would associate with myelopathy. But what is very strange, and I would really like to understand this, is that this fecal incontinence is reported very often. It is also something that most women don't report spontaneously. It is something that pops up in our questionnaires that you have to actively inquire about. But this is very strange because the men are usually superficially speaking, much more severely affected, wheelchair dependent, but they hardly ever complain of fecal incontinence. And the women whose motor functions are much more preserved than the men are very often have fecal incontinence. Don't understand why. Must be something in specific tracts that are affected, but if somebody has an idea, I'd love to hear it later on. And of course, this is the typical signs of spasticity. Yeah, you are probably not very familiar with the EDSS score. Well, the EDSS score was developed in the early 1980s. It is a horrible clinometric score, but it is widely used. It was developed for MS research, but also other neurological disorders with central symptoms use the EDSS. Briefly, 0 means asymptomatic, and the higher the score, the worse you are. And an important landmark is an EDSS score of 6, because that means you are no longer capable of independent ambulation. So that is briefly what you're looking at. So you see, as expected, you see an increase in EDSS over age. But you can also see that most women are ambulatory. Now, another thing that the SF-36 is also not something that is used in pediatrics. Very extensive quality of life assessment. And you can see that, why do I show this graph? You can see that at least it picks up. It shows strong differences between symptomatic and asymptomatic women. The ones affected by a myelopathy score worse on all the measures that measure physical functioning. But cognitively and quality of life is not different. Okay. What was a problem in this study, of course, is the relatively high loss to follow-up. I mean, 12 out of 46 is not great. So we did some statistics to see if we could find some indication of bias, but we could not. If you do the statistics, you find that age or symptomatic status at baseline was not associated with a higher risk of of loss to follow-up. So we hope that the loss to follow-up was random and that this is a representative cohort. In the end, and you can see this is important to realize for the results, that there was almost 8 years between the two assessments, with the baseline and the follow-up. So, did they get worse over those 8 years? Yes, women did get worse over 8 years. At the last group, the 34 that we have 2 measurements for, there were 19 out of 34 who had a myelopathy. Now it's 27 out of 34. So over those 8 years, there's about 8 conversions during follow-up. And there were also a few women who went from independent ambulation to ambulation with a cane. So there is some progress, deterioration. What we also tried, I'm not going to go into the detailed statistics because they are really very, very boring. But what the point is, you want to know how much do they progress. And the only tool we had in this study is the EDSS. And the good news for the women in the study is that the progression in EDSS is really, really very small, almost not measurable. So you can see that for the total group, it's about 0.1 EDSS point per year, which is really not a lot. That is something that you could probably, with a routine neurological examination, that you wouldn't notice. Okay, so that is important to keep in mind. There is progression, but it's slow. Over 8 years, it is hardly measurable by EDSS. Then, maybe you recall from the introduction that women with ALD, that if you just do the plasma very long chain fatty acids, you miss about 15%. So for women, it's not a great diagnostic biomarker. You would have to do DNA. So we did a lipidomics test run, and it does seem that there's a lot of red dots. These are all complex lipids that are strongly different from control samples. So, not surprisingly, there's a lot of complex lipids that contain these very long-chain fatty acids and that are very different. And for a few were so different that we figured, hey, maybe these could be better diagnostic biomarkers. And because they are easy to measure these days, we tested one. And indeed, we tested 2 actually. This is C26 carnitine. Now you can see in one stroke that it's not a good diagnostic biomarker because there's large overlap with your healthy controls. So this one can be discarded. But the C26 lyso-PC, which is a phospholipid, is clearly different in males. It's lower in females. But it seems like it touches the cutoff, but it doesn't. It's just the large triangle but this is just above cutoff. But so this is virtually this is a good biomarker in women. So in screening tests, in metabolic screening tests, this is better than the total very long chain fatty acids, and this could help diagnosis. If you put this in your standard metabolic screen, you're going to pick them up. So to summarize the data on the women, as we already knew for a long time, women are symptomatic. The older they get, the more likely they are symptomatic. Progression is incredibly slow at 0.08 EDSS points per year. And C26 lyso-PC is a diagnostic biomarker that you can use that is faster than DNA diagnostics still. So we can conclude progression is slow. For counseling, of course, it's not good news if you have to tell somebody this diagnosis. But at least what is kind of reassuring is that progression is something that takes decades, not years. And that does change your outlook on life, I suppose. But it also means that you should not include women in clinical trials at this time because you would need like 10 years of follow-up, which is highly impractical. So now I have a little bit left for the men. For the men, we did a much more extensive study. So what kind of parameters did we prospectively collect? Of course, history and accurate neurological examination. And this is a real pain. I don't know if you know it, but the tuning fork is a great tool for the neurologist to assess vibration sense. And it's actually a very, very good measure for dorsal column functions and therefore for myelopathy and also for peripheral neuropathy. But there is a very old technique. You can, of course, record if it's absent or present, but then you only pick up the more serious cases. But somebody developed a tuning fork that is semi-quantitative. So you tap it, and then there's a reading on the top, a number from 0 to 7, and you can quantify the vibration sense, and you can look up in tables what is normal for a certain age, because also healthy aging means it decreases the vibration sense. So we did that. It's a real pain because it takes an incredible amount of time, but as you will see, it was not in vain. Now, what did we also? We also assessed the 6-minute walk test, timed up and go. So the 6-minute walk test is exactly what it says. You have somebody walk for 6 minutes and you record how many meters are covered. Of course, it's you could say it measures something that has some real life relevance. Problem is, it's not very sensitive and it highly depends on patient motivation, what shoes they're wearing, all kinds of stuff. So it's not sensitive. Then we did the timed up and go, the EDSS, of course, and some other myelopathy scales, and lots of questionnaires. So, we used the same definition of myelopathy we used in the women, so that you had to have both signs and symptoms of a myelopathy. And then we would flag somebody as symptomatic or asymptomatic. Now, so far we looked at cross-sectional data, which we will briefly review first, and at some longitudinal data, the 2-year follow-up, to see if we can actually measure progression over this relatively short period of 2 years. Because if you see your patients, usually they do not report great progress over 2 years. It is also, so we were kind of excited to see if we could measure it with the 6-minute walk test and things like that. So, if we deduct the under 16s, we had 46 males left with an average age of also very high for the pediatrician, 45. Spread all over the place, young and old. Interesting to note, the oldest asymptomatic patient we had was 45, somebody who really got a clean bill of health. But there was also a man of 63 who reported no complaints whatsoever. He was very active, but when you examined him, he did have, a Babinski sign, which is obviously not normal. So he had signs and no symptoms. So in he felt he was completely asymptomatic and he had no disability whatsoever. But as a neurologist, you're of course a little bit worried about his spinal cord function. Youngest symptomatic was 22 with only signs, again Babinski signs, but somebody who was otherwise very active, and with signs and symptoms already 28. Another interesting finding, also a little bit disturbing. We did MRI scans for the entire cohort, and this every patient is represented by a little dot. Now this is obvious, it is the age. And this column is the LUS score. And the LUS score it runs from 0 to 32. And it's developed to quantify white matter abnormalities in cerebral ALD. And basically, it should be 0. And what you can see is that a large amount of patients, 20-25%, has abnormalities, sometimes even quite high LUS scores, with scans that look like this. Here you can see the typical lesion in the splenium of the corpus callosum with extension in the white matter. Here the other known presentation of ALD with lesions in the genu of the corpus callosum and extension in the white matter. These definitely had cerebral ALD at some point. They were not picked up, so they were not transplanted. So you can wonder if cerebral ALD is as relentlessly progressive as we always say. It does seem that in a certain percentage of cases, it can arrest spontaneously and remain stable for years or decades. So that is, interesting. Not something that you can act upon, because if you find cerebral ALD, you have a narrow window of opportunity for treatment. But nonetheless, interesting. So, now the last numbers that I'm going to unload on you. So we had follow-up. Time between visits was reasonably as planned, almost a year between visit 1 and 2, 2 and 3, and almost 2 years between visit 1 and 3. Sorry. Yeah. Okay. So this is from retrospective data. But you can see that adrenal insufficiency is indeed something that that occurs at early age, and that affects enormous amounts of maybe 70% of men before they're 18. So frequent presenting symptoms. And what was interesting to us is that about 15 to 20% of very old patients, some of them into their 70s, still had completely normal adrenal function. So apparently, it is also possible never to develop adrenal function, dysfunction. The myelopathy is actually has a penetrance of almost 100%. You can see that in between the 20s and 30s, you can see that onset starts, and by age 60, virtually all men have a clinically detectable myelopathy. All right. So now the longitudinal data. So, is there measurable progression over 1 or 2 years? And the answer is yes. In those 2 years, there was only one man who we had to flag symptomatic. But from those who were symptomatic, you could see that they got worse. There were a few who had to switch from a cane to an ambulator or switch to a wheelchair, etc. And what was also interesting is that we could find a very clear change in that quantitative vibration sense with the tuning fork on the big toe. So we didn't do it for nothing. So that is interesting, because that means that the dorsal columns are, the progression of the damage to the dorsal columns is very measurable. And that is hopeful for the DTI studies. Okay. Well, this horrible table, the only thing we could detect progression on was on the 6-minute walk test, surprisingly, even with a 1-year interval. The SS-PROM, which is a myelopathy scale, the EDSS, unfortunately, and the timed up and go. So, our preliminary conclusions are that progression of myelopathy is detectable by clinical outcome measures at 1 and 2 years of follow-up. But this also means that the minimum duration of a clinical trial with current outcome measures should be 1 or 2 years. And that is something we noticed that pharmaceutical companies are really not that keen on. They want trials that last 6 months or 1 year. But with our current, the current outcome measures we have, it's absolutely not feasible to do less than 1 or preferably 2 years. So, unfortunately, this is the only data that we've analyzed so far. So I hope maybe in the future I can show some flashy MRI pictures or some nice new surrogate outcome measures. But that unfortunately will take some time. So of course, all this long follow-up is a lot of work. And there's lots of PhD students and colleagues from other departments who contribute to it. And we hope to be still doing this in 5 years and then come up with some usable data for patients. So thank you for your attention, and if you have any questions, then I'd be happy to try to answer them.
So we're going to run the microphone around here. So maybe we'll start with Sue over here.
Come on. Thank you for sharing that exquisite long-term follow-up data, which is very difficult to collect. So congratulations. A comment and a question. My comment would be that in your metabolomic data, one strategy might be to develop ratios that allow you to enhance the visibility of change. That's been very valuable in newborn screening and is a technique that's well established and can be very powerful to create more robust biomarkers. So a thought about that kind of analysis. And then a question. One of the things that's a problem with newborn screening is that as soon as you start, you figure out you don't know anything about the disorder that you thought you knew. And you've already begun to observe that when you do a little more longer-term follow-up, which is that we really don't know the natural history well. We're going to end up having bundles of babies that may never have any symptom at all, but we know nothing about how to do that, how to consider that. What do you think is the degree of penetrance ultimately for the disorder? Because that's really the heart of what we learn from a true natural history from birth study.
Yes. Well, thank you for your comment. I'll be sure to pass it on to the lipidomics people so they can mess around with the data and maybe find a ratio that is even better. Yeah, as for your question, I can't be 100% sure. That is something that we will learn by following the newborn screening cohorts. But I do think that the penetrance for the myelopathy in men is virtually 100%. And adrenal failure penetrance is probably 80-90% lifetime. Cerebral ALD, much lower. We estimated lifetime risk at about 60%. So that's, but maybe, maybe if you have a true newborn screening cohort, maybe that penetrance we determined from our cohort is still slightly biased. Maybe. Yeah, time will tell. Much time. Yeah.
Not to editorialize too much, but we should talk to you a little later too, because there's going to be opportunity, I think, to collaborate with different states that are doing newborn screening and try to pool data, but it's not inherently easy. So if you have some tricks to do that, well, I know, but you've learned a lot of tricks there, so we should discuss how we might go about doing this.
One of the things that's become important in studying MPS diseases, and Paul and Linda Polgreen have recently published on inflammatory markers in the CSF of patients with MPS, and I didn't hear you mention anything about inflammatory markers in ALD. What do we know about that?
I know very little about that. We didn't do that, but there is somebody in the audience who does, actually. That is something that has been done in this institution. They did look at CSF of cerebral ALD patients. So maybe I can defer to you, Troy.
So the next question that I have is about the prevalence or incidence of ALD in the Netherlands. And I'm curious about your the ethnicity of your group. Are they all from the Netherlands, or are they from surrounding areas of other countries of Europe there? Because that's interesting to me, the thought of some of the variation in the presentations of the individuals.
Well, yeah, our cohort is almost exclusively Dutch, Caucasian, maybe 3 families from Moroccan descent, quite a few immigrants from Northern Africa, but it's very ethnically it's very homogeneous, yeah. So it's difficult to say if there's genetic influences from ethnicity. It's something that we cannot learn from this very homogeneous cohort.
Very interesting talk, and I wanted to, I'm the endocrinologist as we talked, wanted to ask a couple of questions about the adrenal insufficiency in, you're not doing newborn screening in the Netherlands yet, is that correct?
Correct.
Okay. How early in your groups have you seen adrenal insufficiency show up?
Yeah, that's difficult. The youngest ones that were diagnosed were between 3 and 4. But yeah, you know that better than me, but sometimes there can be very vague symptoms. Sure. So if that is actual onset, if the moment of diagnosis is actual onset, or actual onset might have been a year or even longer before that, I can't really tell. Sure. Yeah.
And have there been any cases in women developing adrenal insufficiency?
I've never seen it, but in the literature there are a few. Yeah, but they estimated that at 1% of women or something, so it's very rare.
I just wanted to put a plug. The Pediatric PES Drug and Therapeutics Committee has actually addressed newborn screening for adrenal insufficiency in a guideline, if you will. We're going to be presenting that this weekend at the Pediatric Academic Societies, and it's been submitted for publication, but unfortunately it's based on very little data because we don't have the natural history yet, and so we're providing guidelines to then try and apply actual data too. So I think it's important,
well, that's
important in development.
That's a good step.
We partnered with New York and California, Minnesota, places that are already doing the newborn screen to say, what are you seeing and how are you approaching it?
Yeah, that's great. Yeah.
Can I add something quick in the interim too? So virtually all the data we're looking at is motor data. I mean, is there neuropsychologic outcomes that have been looked at in the women and the adult men? Can you just speak to that?
Yeah.
Was it buried in one of those tables?
No, no, I left it out.
Oh, okay.
No, we did neuropsychological evaluation cross-sectionally on all the men, and the ones with normal MRI scans are normal. They function as well as controls. Okay. Yeah. The ones that have extensive white matter abnormalities obviously have problems. Yeah.
For that subset of males that have cerebral disease, is it always arrested, or are you seeing gadolinium enhancement? Are you seeing progression over that study period in the LES score?
Yeah, I didn't mention that. I should have. All the men in this study, we excluded the ones with active cerebral disease because we wanted to study primarily the myelopathy and those aspects of the disease. So yeah, there's a few adults we have with cerebral ALD and GADO enhancement, but they were excluded from this data set. Yeah.
How many of them were there?
4 or 5. Yeah. Didn't end well.
From a pediatric endocrine standpoint, I was involved in the implementation of newborn screening in the state of Connecticut, which I think was the second or third state in the US. So they rolled out screening about 3 years ago. And one of the huge advantages was we were picking up siblings, so boys, so brothers, who had asymptomatic adrenal insufficiency. So we were therefore reducing morbidity pretty significantly by intervention with hydrocortisone.
Yeah. Please talk to the Dutch health authorities and tell them these things so they can, hurry up.
So this changing pace a little bit. I was interested that the arms are spared and protected in this, and why? Is there some biology of arms that are different than legs?
Well, I can speculate. I don't know why, of course, but this is a very, very slowly progressive axonopathy. And we know also from neuropathies that the longest axons are the most affected. So they're the first to go. And I think if you wait long enough, if you would have a man of maybe 97 years old, that eventually probably the arms will be affected. But the age range we see, the arms are not affected. But I think it's a slowly progressive process, and if you wait long enough, the arms will also go eventually.
So I can answer Liz's question to some extent. We've spent a lot of time looking at the cerebral spinal fluid of these boys, and we know a few things. One, they don't have like a T1 or T2 phenotype to lymphocyte cytokine production. They do have very high levels of monocyte chemotactic protein and chitotriosidase, which are both monocyte-specific cytokines. So that's the kind of skewing we see, is a lot of monocyte-specific inflammatory factors, which is interesting because ABCD1 expression is highest actually in CD14 monocytes. So maybe there's something to that. And then I had a question, is that often we think about boys in adolescence and puberty, if they don't develop cerebral disease, they may escape the incidence of cerebral disease at that time frame from 10 to 14 years of age or 15. Do you have any ideas why that might be, if they make it that long?
No, I'm sorry, I really have no idea. No, it's still a mystery why some people develop cerebral ALD and others don't. I really have no hypotheses why it should be, age dependent. But I do think that it might not be as age dependent as we think. Maybe I do think that many cerebral ALD cases in adulthood, in most cohorts, I think they the cerebral ALDs in childhood are picked up, are followed up, and I think that we are missing a lot of them in adulthood. I mean, there does seem to be a vulnerability in early age, but I don't think it's that rare in adulthood. We have quite a few of adult men who developed it in their 30s or 40s.
Do you think the the disease is occurring in adulthood, or maybe it had occurred in childhood and arrested, and we just never knew about it until you looked as adults?
Yeah, both, I guess. Yeah. Yeah, but we see indeed, like in the cohort, you see a lot of people with lesions that are no longer GADO-enhancing and are not progressive. But yeah, we have a few that actually really have progressive lesions that look very much like cerebral ALD in childhood, and they don't have a good prognosis, many of them.
Do you have any sense of the mortality in the younger group in the Netherlands in terms of adrenal insufficiency or CNS disease mortality rates?
We never systematically recorded that. From adrenal insufficiency, low, I guess. Yeah, and from transplant, that Paul knows that better than me, but there is a few % mortality in bone marrow transplants.
And I was just thinking of not transplant related, but just disease, adrenal insufficiency, crisis related.
We think that if the adrenal insufficiency is treated, and there's no cerebral ALD, that people have a normal or near normal lifespan. We have lots of older folks with disabilities, but otherwise healthy.
Thank you.
Other question?
I'm wondering if you can comment on role of triggers in setting of the rapid progression of cerebral ALD. I know there is some thought about that, some patients.
Yeah, there's a few case reports published on head trauma as a precipitating factor. So men who had a severe brain contusion and then a few months later developed cerebral ALD lesions around the contusion. And we actually once saw an older man who developed a stroke. He recovered from the stroke, and then he died of cerebral ALD that was also triggered around the stroke lesion. So basically, it seems anything that causes a focal brain lesion can be the starting point for the cerebral ALD. And yeah, there's also the hypothesis that pro-inflammatory states or infections, sepsis can also be a trigger. But yeah, that's still largely not well understood what happens there. I mean, it's obvious you need the biochemical defect to develop cerebral ALD, but there has to be something else to develop the cerebral ALD lesions. And nobody has been able to find a clear modifier gene yet, but that's maybe because it's mostly environmental, who knows. All right.
Thank you, Mark.
Thanks.
Oh, sure.
There you go, Paul.
You have been